Welcome once again to 10 Minutes with Harry and our series on the interpretation of the normal pacemaker electrocardiogram. Today, we would like to talk about conduction system pacing. This is a topic unfamiliar to most people who report ECGs, and in fact, unfamiliar to most of the people who implant pacemakers. Because conduction system pacing is a new form of pacing. Historically, though, many of the early attempts were made to pace the heart via the conducting system. This was using Bachmann's bundle, which is a bundle that lies between the right atrium and the left atrium, close to the sinus node, and therefore conducts from the sinus node almost immediately into the left atrium and as well as to the right atrium. One can see that if one paces here, the physiologic effects of pacing the atrium would be much better than through the atrial appendage, which we now use. Also, His bundle pacing was also started early on without much success. However, His bundle interest was rekindled when it was shown that right ventricular apical pacing could cause left ventricular dysfunction in some patients. This, however, His bundle pacing was limited to right ventricular attempts, and the available technology was very poor, and therefore small numbers were done, and they weren't particularly successful. Then we started non-apical right ventricular pacing, and in the hope that this would show better left ventricular function, but this has never been conclusively proven, and therefore today His bundle pacing has again been regenerated and is available by using the right atrium using active fixation leads. The result is ventricular pacing with a narrow QRS. More recently, deep septal pacing with recruitment of the left bundle branch, and sometimes the right bundle branch has been attempted successfully. And the characteristic ECG patterns of conduction system pacing can be very confusing. Hence, I will be reviewing them. His bundle pacing, let us look now at an atrial flutter with high degree atrioventricular block, and this is the appearance pre-pacing. When one paces from the His bundle, you can see, though, the ECG looks almost identical. The features are that there is a small bipolar stimulus artifact. There is a latency period, as can be seen on the red highlight, and this represents conduction from the His bundle to the ventricle, similar to that which occurs in the normal PR interval, but is, of course, the latter part of the PR interval, or what we call the HV interval. And then the QRS is almost identical. On the ECG, however, with His bundle pacing, there are actually two appearances. The first is selective, direct pacing from within the fibrous capsule surrounding the His bundle, so that it just paces the His bundle. However, there is also commonly seen a non-selective His bundle pacing, which also involves the adjacent myocardia. Let us review then the selective His bundle pacing, which is similar to what I've already shown you with the atrial flutter patient. Here we have pre-pacing and His bundle pacing, and it can be seen that both ECGs are almost identical. To highlight the differences, one can see now with V4, you have a small stimulus artifact. There is a very small, narrow latency period, and then a narrow QRS. The T waves with selective His bundle pacing are identical, both pre-pacing and following His bundle pacing. With non-selective His bundle pacing, we see a different appearance on the electrocardiogram. Because non-selective depolarizes the surrounding myocardium, the result is as you can see, a stimulus artifact followed by what we call a delta wave. However, it is preferable to call this a pseudo-delta wave, as a delta wave belongs to the Wolff-Parkinson-White syndrome. The delta wave represents conduction through the tissues around the His bundle into the myocardium. And the other feature, though, is that there are now T wave changes. Let me show you this on these ECGs. To the left is pre-pacing, and to the right is His bundle pacing. When one looks at, say, lead 1, you can see in pre-pacing, there is an upright T wave, and then following His bundle pacing, there is an inverted T wave. And this is quite a feature of conduction abnormalities, such as going through with Wolff-Parkinson-White and going through the pathways which are not through the AV node. And once again, with V6, you can see upright, and in pre-pacing and His bundle pacing, it is an inverted T wave. The other interesting feature of His bundle pacing is that it may correct a bundle branch block. The level of differentiation into the bundle branches may occur high in the His bundle, and this is called longitudinal dissociation. This means that the right bundle branch and the left bundle branch, including the anterior and posterior fascicles, these may be differentiated very high up. The His bundle pacing may completely or partially correct a right or left bundle branch. And here we can see a right bundle branch block pacing with 2-to-1 AV block. This is what happens when we have this His bundle pacing and the right bundle branch block is resolved. In this case, it is a non-selective His bundle pacing. You can see then, pre-pacing to the left, there is a right bundle branch block in V1 and V2, whereas the right bundle branch has resolved. We can also see that the small stimulus artifact, and there is that pseudo-delta wave and the abnormal T waves that occur as a result of pacing through the non-selective His bundle. So His bundle pacing can be technically challenging. At the time of pacing, we may have high pacing thresholds, or post-operatively, these can gradually rise with time. There can be cases of poor sensing, and depending on where you placed your lead, we may also have direct atrial capture, which is not what we really want. So now interest in direct left bundle branch or deep septal pacing has occurred in the last few years. Let us review the anatomy. The left bundle branch is a fan-like structure. As you can see, above is the His bundle, then it is into the left posterior, left anterior fascicle, and the right bundle branch. Also shown is a left bundle branch block occurring. With our pacing, we put a bipolar screw-in lead and anchor it deep into the ventricular septum, and therefore into the left bundle branch or very close to it. Another feature of this is that there may be anodal pacing. That means that the current flows from the cathode or the tip of the lead back to the anode, which lies just behind it. And in this way, it may pace the right bundle branch as well. So let us now have a look at the indications. It's usually in a left bundle branch block where patients require ventricular pacing as well. Because there is no fibrous capsule around the left bundle branch, as it is a fan-like structure, the QRS is mostly fusion between the conducting system and the surrounding myocardium. Appearances will depend on the voltage and, of course, on the level of the pacing. Anodal pacing if it encroaches the right bundle branch. Let's now look at an ECG with a left bundle branch block and a first degree block requiring pacing. With deep septal pacing at a very low voltage of 0.5 volts, the result is that the ECG QRS now is narrowed considerably. Look to the right at leads 1 and V2 and V1 and V2, and you can see the stimulus artifact and that there is a right bundle branch block. This is in fact quite a narrow QRS, so it's an incomplete right bundle branch block. And there is no latency here because we are low down and we do not really see much of a pseudo delta wave as well. When the voltage is increased to 8 volts, once again we look at the ECG and we can now see the stimulus artifacts. There is a pseudo delta wave, and this is conduction, of course, through the surrounding myocardium in the septum rather than only in the left bundle branch. And now we have actually lost our right bundle branch block because we have got this anodal pacing. If one looks also at the main ECG, there's a left axis deviation, and this suggests that this is a left anterior hemiblock, and for that reason, the pacing is primarily through the left posterior fascicle of the left bundle branch. So let us just review this case once again. Pre-pacing, a wide QRS, pacing at 0.75 volts. We can see now a much narrower QRS, and a right bundle branch block or partial right bundle branch block. And when at 8 volts, we have now got a small delta wave present. Deep septal pacing is not as technically challenging as His bundle pacing using the right equipment. It has excellent voltage thresholds and sensing. Our indications are yet to be defined, but it may well be very useful for cardiac resynchronization therapy. Today, we do use this for CRT, but only in cases where direct left ventricular pacing has failed. So what have I learned? We can now pace the ventricles via the conducting system. Conducting system pacing will retain a narrow QRS or correct a bundle branch block. His bundle pacing may be selective or non-selective, where non-selective paces the surrounding myocardium. And the newer form of deep septal pacing is generally non-selective and may correct a left bundle branch block. Thank you.